Okay, Assalamu alaikum everyone. So we are all here today for the third and final session of finale of ECG Made Easy. And I'm Dr. Sairah Sadaf, and let's start. I get a challenging. Okay, let's start with something good. Like if you're not willing to learn, so no one can help you. But if you are determined to learn, then no one can stop you. And this is especially for my PGs. We have been through the rhythm identification, axis, most importantly, hypertrophy, bundle branch block, and ischemia. So today, this session is about the arrhythmias, the bradyarrhythmias and tachyarrhythmias. So in bradyarrhythmias, we will go through AV blocks, and in tachyarrhythmias, we have a lot of arrhythmias. So let's tackle each at a time. Okay. So as we all know that there are first degree, second degree, and third degree AV block, right? And then among the second degree, we have further two types, type 1, type 2. Type 1 is known as Vancke-Bag or Mobitz type 1, and type 2 is known as Mobitz type 2, right? So this is a very good, a very nice slide. You can take a screenshot of it. Now, when we talk about the blocks, where do you have to look? First of all, let me clarify one thing, that AV blocks mean the delay of the electrical impulse from the atria to ventricle. AV block, atria to ventricle, right? So there will be, the atria will contract first, and there will be a more than usual delay in the contraction of the ventricle. So this delay, the whole atrial cycle, that is represented by PR interval, right? That has been discussed in our first session. You will be having two type of prolonged PR intervals on ECG when we are talking about AV block. Constant PR intervals, they will be fixed in all the leads or throughout the ECG. While the variable PR intervals, you will have variable PR intervals. For example, like in the same lead, let's say lead 2, we used to look for the PR interval in lead 2. So you will have a different PR intervals in the same lead. I will show you how. So when you are having the constant PR interval, it may be first degree AV block or it may be second degree type 2 AV block. Just memorize it. And when there is a variable PR interval, although prolonged, it's a variable PR interval, it may be either second degree AV block type 1, Vancke-Bag or Mobitz 1, or it may be third degree AV block, right? So just memorize it and let's move forward. Okay, now this is a very beautiful story I'm going to tell you. Not very beautiful story. Actually, this is a very sad story. And let's see how to fix it. Now, just imagine, I just want all to just imagine that the P wave is a character, and let's label it a wife, and QRS complex is husband, and the pacer that is required for the correction of the problem, let's call it the counselor, the marriage counselor, as we all know, right? In the normal sinus rhythm, the wife, the P wave, it waits at home for the husband, QRS complex, and the husband comes home, the QRS complex, the husband comes home on time every night. So this is a normal sinus rhythm. Let's say, now this is the wife, P wave, and this is the QRS complex. As you can see, the PR interval is fixed. P wave is normal with height and width. And the duration of the PR interval from here to here, this whole PR interval is constant and within the range. So what is the normal range? 3 to 5? Yes, small squares, 3 to 5 small squares. So as you can see, so this is constant. So this is a normal sinus rhythm. Wife is patiently waiting for the husband QRS complex, and husband QRS complex is coming every day, every night at the same time. Let's say at 8 o'clock, 8 p.m. at night, every night. Now, first degree AV block. Now look at the ECG. It is very self-explanatory when we consider P wave as wife and husband as QRS complex. Now, as you can see, the wife is still there, but the husband has started coming home late. PR interval is prolonged. The QRS complex has started appearing a little bit late, but it is fixed. Although husband is coming home late every night, but he is coming at a fixed time. Previously, he was coming at 8 o'clock. Now he has started coming at 9 o'clock. But time is fixed. But there is something wrong. So the wife is waiting at home. The husband QRS complex comes home late every night, but he always comes home and it's at the same time every night. Although it's 9 o'clock, but it's fixed. But he is coming late. So what have to be done? Be alert, be conscious, treat the cause. Right now you don't know the cause, but treat the cause anyways. Maybe it's secondary to some drugs, secondary to anything. So there's no need for pacing right now. It's just PR interval is prolonged. Not that prolonged that the QRS complex has started missing to appear. At least he's appearing. At least QRS complex is appearing and appearing at a fixed time. So there's no need for pacing, right? Samajh aayi? Okay, now next, second degree block type 1, Mobitz type 1 or Wanky bag. That was with the variable PR interval. Now look at this ECG. Can anyone interpret it? As you can see, this is P wave, this is QRS complex, and you can see there. Yes, now as you can see, this is the progressive lengthening or prolongation. The PR interval is getting prolonged progressively. So here the husband was coming at 8, and then he started coming at 9, and then he started coming at 10, and suddenly one night he did not come home. So that is very suspicious. Now let's see. So now the wife is waiting at home. The poor wife, she is waiting at home the same time. The husband QRS complex comes home later and later and later and every night until one night he doesn't come at all. So that is as you can see, the QRS complex is missing here. So this is the variable PR interval prolongation, right? Now, and yes, technically, the husband must come home at least 2 nights in a row to see this pattern. Like this have to be occurred twice. Then you have to comment that this is a Wanky bag. Now, why it may happen? It may happen due to high vagal tone. It may happen during sleep. So it may be normal, or it may be pathological. It may be diseases of the conducting pathway. Of course, it's maybe due to that. Now, it's usually benign, but may be associated with acute MI. So don't forget that. It needs temporary pacing because he missed one night. So now the counseling should be there. The second degree AV block, Mobitz type 2. That was the fixed PR interval. Now, what's happening here? Can anyone elaborate? PR interval is fixed, but QRS complex has started dropping. Now what's happening here? Let's see. The wife P wave is waiting at home. Sometimes the husband QRS complex comes home, sometimes he doesn't. When he comes home, when he does come home, it's always at the same time. but suddenly he starts disappearing and then he starts coming home. So this is usually more serious. Of course, this is very serious than type 1, and it will sometimes require counseling, the pacing. And due to fault in the bundle of hairs, it can progress to third degree. Of course, it needs pacing. Definitely, it needs pacing. This is not a thing that will be corrected by just giving dopamine or something like that. Now, this is the Mobitz type 1 ECG. This is the Mobitz type 2 ECG, as you can see. So as you can see in the Mobitz type 1, there is a progressive prolongation, while in Mobitz type 2, the PR interval is fixed, but the QRS complex is missing in between, So this is the variable PR interval, QRS variable PR interval prolongation. This is the fixed PR interval. We have another type of second degree AV block, and we call it 2-in-1 and 3-in-1. It's very self-explanatory. 2-in-1 means the one QRS complex will be followed by 2 P waves, and 3-in-1 means one QRS complex will be followed by 3 P waves. What does that mean? That means one atrial impulse is conducted while the next is blocked. Okay? Because this is a problem with the conduction of the electrical impulse that have supposed to be coming from the atria to the ventricles. So the one impulse is coming from atria to the ventricles, but second one is blocked. Then again, the third one will go and fourth will block. And then so on. While in case of 3-in-1 means one will convey and 2 will block. One impulse will be conveyed and 2 will be blocked, right? So that's very simple. So yes, and 3-in-1 block is also known as high grade AV block, because that will be leading to the cardiac arrest. If not, like if no intervention is done promptly, the patient will develop cardiac arrest. These are different ECGs showing you the third degree AV block. This one is the very serious one. And this one I have already shown you in the previous slide. Arrhythmias. Now, we have already talked about the bradyarrhythmias, but we will be having 1 to 2 slides on the bradyarrhythmia as well in this part of this segment as well. Bradyarrhythmias, tachyarrhythmias. Now, in tachyarrhythmias, we may have narrow complex and broad complex. And in both, we may have regular and irregular rhythms. And on that basis, we can diagnose them. This is, what is this? This is sinus bradycardia. What is the sinus bradycardia? In which there is no prolongation of the PR interval. It will be just slowing of the heart rate. That's it. Like in this, the P wave will be normal. The QRS complex is coming at the right time, immediately after the P wave. And then the rhythm is regular. Rate is less. The heart rate is less. PR interval is normal. Duration is normal. P wave is visible, and every time before, each time it's coming just before the QRS complex, that is normal. PR interval is normal. And usually it's benign and often called by, due to the drugs, like for example, beta blockers. Sinus tachy is same as sinus brady, just with the difference that it is the increase in heart rate. So we will have a regular rhythm, rate more than 100 beats per minute, QRS complex duration normal, P wave visible before each QRS complex, PR interval is normal, between 3 to 5. The impulse generating the heartbeats are normal, but they are occurring at a faster pace. That's it. It may occur during exercise. Now, sinus arrhythmia, this is also a normal feature, a physiological feature. Sinus arrhythmia means the heart rate increase during inspiration and decrease during expiration. Okay? Every P wave is followed by a QRS complex. Duration is normal, shape is normal, position is normal, QRS complex is normal, PR interval is normal. Acha, about the atrial fibrillation. Now, atrial fibrillation comes under narrow complex tachycardia, but with irregular rhythm. We all know that. If now, what may happen? There may be absent P wave. There are fibrillatory waves. Fibrillatory, as you can see, these are not the normal waves. These are haphazard, small, tiny waves. They're appearing. It is irregular QRS complexes, not coming on the same interval. QRS complex normal, yes, and the QRS complex normal duration is less than 3. So sometimes it may reduce. So atrial flutter, it's very popular because of its sawtooth appearance. Saw means the saw, and you can see its shape, sawtooth appearance. You may have 2-in-1, 3-in-1, or 4-in-1, like the abnormal waves coming here. The atria, they commonly 250, they are contracting at 250 to 300 beats per minute, that fast. While the ventricles depend upon the response, it's regular. Okay, now the regularity is the atria are regularly contracting, but contracting very fast. What about the P wave? P waves are negative. They may fluttery atrial waves. About the supraventricular tachycardia, these are the narrow complex tachycardias, and these are usually regular in rhythm. So there are different kinds, different types, AVNRT, AVRT, AT. I will show you what are these. Okay. So rhythm is regular, as I have already mentioned. Complexes will be narrow. Rate will be more than 140 to 200s. And usually it's always in 200s. It starts from the 180s and goes up to 200s. Below that, usually these are not SVTs. QRS complex duration is normal, maybe shortened. That's why we call it narrow complex. Sometimes it may be normal even. P wave often buried in the preceding T waves, or even QRS complexes, or even in the S wave, even in anywhere. Or maybe it may be visible sometimes. If it is visible, okay, fine, but sometimes it's buried in the T wave or in the QRS complex. What's happening here? Just a brief pathophysiology of that. Impulses stimulating the heart rate are not being generated by the SC node, but instead are coming from a collection of tissue around the AV node. Re-entrance circuits having slow and fast paths. So these are different kind of ECGs of SVT. It may appear like this, it may appear like this, it may appear like this. Someone asked why you have to look into the lead 2. I think Barsha asked, and I want to ask from my PGs why you have to look for the arrhythmias and why you take the rhythm strip of lead 2, because it is sharing the same axis as of the heart. Because the lead 2, the axis of the lead 2 or the lead 2 is sharing the same axis as that of the heart, or is in the same direction, not the direction, it's sharing the same direction of the cardiac impulse. That is a better way to interpret it. Now, these are different kind of ECGs, or the appearing of SVT in different leads, so that you won't miss any of it. It may appear upright like this. It may appear downwards with downward deflection in AVR. As we know, it will appear like this. It may appear with the R and S wave both of the same height and depth. The most commonest type is the AVNRT. So this is a fast, slow slow and fast type of the SVT. 90% of the cases have AVNRT. In most cases, P wave is hidden in the QRS complex. P wave is sometimes seen after the QRS complex. It will represent itself as pseudo S in lead 2 and pseudo R in lead V1. As you can see here, this is very self-explanatory tracing of ECG. You want to take the picture, take a picture. Want to take screenshot, take a screenshot. And let that sink in. G. So then there is atypical AVNRT. 10% of the cases have this. P wave comes before QRS complex. Junctional rhythm. What is junctional rhythm? Now, junctional rhythm, it comes under, first of all, it's a regular rhythm. It originates in the AV node. Now, we're not talking about accessory pathway, something like that. We're talking about from where it's coming from. Rate 40 to 60 beats per minute. Normally, QRS duration normal. P wave is visible. It sometimes not visible. If it visible, it is inverted in lead 2 and may appear before or after or hidden or buried in the QRS complex. So in junctional rhythms, the P wave usually is not visible. But if it's visible, it will appear as inverted in lead 2. It may appear before, after, or it may be hidden in the QRS complex. Rate is same as the QRS. So that's why there will be no dissociation, and that's why rate is the rhythm is regular. Now there are different types of junctional rhythms. The terminology used to identify the type of the junctional rhythm depends on its rate and is as follows. आज मैंने अपना marker नहीं निकाला. Okay, first of all, junctional bradycardia, as the name indicates, the rate will be below 40 beats per minute. How you will differentiate junctional bradycardia from sinus bradycardia? G, anyone? How will you identify or differentiate on the ECG tracings that it's junctional bradycardia and it's not a regular sinus bradycardia? P wave may be absent, and if it's present, it will be inverted or it will be buried in the QRS complex. Okay, that's all. Junctional escape rhythm rate is between 40 to 60 beats per minute. Accelerated junctional rhythm, when rate is between 60 to 100, and you call it junctional tachycardia when the rate is above 100 beats per minute. And at this point, that is the very difficult point. The junctional tachycardia and junctional bradycardia, these are the two things that you have to differentiate them from the sinus bradycardia. And the junctional tachycardia, you have to differentiate between junction, not you have to, I'm sorry, I'm saying you have to, but in case of junctional tachycardia, it's quite difficult to tell them apart, like junctional tachycardia and SVT. It's difficult to tell them apart on just looking at ECG tracings. They look the same. And you have to look into the, for the findings in the lead 2. Now, sinus tachycardia, now when you will have this ECG, the P wave is normal. It's just coming before the QRS complex. But there now, what are different possibilities? It may be sinus tachycardia. It may be sinoatrial reentrant tachycardia. It may be focal atrial tachycardia. I will tell you what's focal atrial tachycardia, don't worry. Okay. And then junctional tachycardia. Okay, now you may have a P wave coming before the QRS complex, but it is inverted. So it may be a junctional tachycardia or it may be AVNRT. So don't be afraid, don't be just get scared of this name AVNRT, just it's SVT. So it may be junctional tachycardia or it may be SVT. So you cannot tell them apart just like that. Now, you may have this, there is no P wave. P wave is there, but it is buried in the QRS complex. You cannot see it properly. So it is buried inside. So it may be junctional tachycardia or it may be SVT, as I have already mentioned. Again, the P wave is coming here as appearing as pseudo. Now this is pseudo S. So it may appear like this. So it may be AVNRT, it may be junctional tachycardia. AVNRT means SVT. It may be SVT or it may be junctional tachycardia. Now again, P wave is coming here. These arrows are indicating the presence of P wave. Now it's maybe coming here after the QRS complex. merging in the ST segment. So it may be AVRT, AVNRT, junctional tachycardia. Starting from here, then you're having a tachycardia on ECG tracings or on the cardiac rhythm, on the cardiac monitor. First of all, you have to look, is it sinus rhythm? Sinus rhythm means P wave is coming before QRS complex, or QRS complex is following the each P wave, or P wave is upright in lead 2. So it is a sinus rhythm, yes or no. If it's yes, then you don't have to do anything else. Just get out of this scheme. No need to follow this scheme. Okay, now let's say the rhythm is not sinus. It is not a sinus rhythm. So you will label it as tachyarrhythmia. This is very important slide. Then you have to label it as tachyarrhythmia. This is the practical algorithm, what you have to follow and how you have to follow. First of all, tachycardia. Then you will look into the sinus rhythm. P wave hai, nahi hai, upright hai, coming before the QRS complex or what? If yes, then it's sinus tachycardia. Just leave it alone. I mean, there's nothing to be too much worried about. And then if it's not sinus rhythm, just first of all, it is the tachyarrhythmia. Now you have to look at the QRS complex. Is it wide or it is a normal? The duration of QRS complex is normal. Let's say it's wide complex tachycardia. It may be VT or it may be SVT with aberrancy. Just first of all, just leave it alone here. Coming back to our main topic right now, the narrow complexes. Now let's say the QRS complex is duration is less than 120. So it means it's supraventricular tachycardias. When the QRS complexes are broad, most of the time, these are ventricular related tachycardias. When the QRS complexes are narrow, it means it is related to the something above the atria. Something above the ventricles. Accessory pathway, atria, or whatsoever. ठीक है, समझ आ गई? Now, supraventricular tachycardia. So it is again irregular or irregular. First of all, the irregular, we all know that atrial fibrillation comes here, atrial flutter comes under this, and multifocal atrial tachycardia, also known as MAT, right? So I will discuss it. Okay, and in the regular SVT side, we may have a sinus tachycardia, we may have AVNRT, AVRT, that just resembles the junctional tachycardia. इसको रहने दे. Atrial flutter may be with fast heart rate, fast ventricular rate, and ectopic atrial tachycardia or focal atrial tachycardia. This is also known as FAT. We have MAT and we have FAT. This is focal atrial tachycardia. It's usually regular, and the multifocal atrial tachycardia is irregular. And then it may be a junctional tachycardia, as I have already mentioned. Right? मेमूना गुड. क्या कंफ्यूज कर रहा है? वो भी आ जाएगा, डोंट वरी. As the name indicates, multifocal means there will be with every complex there will be a different shape of the P wave. Multifocal atrial tachycardia. First of all, just focus on the name. Multifocal atrial tachycardia. So atria is related to P wave. Multi means many faces, many shapes, morphologies. So every time there will be a different P wave. Inverted, this, that, tedi, medi, upper, niche, whatever. D-shaped, D-morph P waves. That is multifocal tachycardia. Simple, atrial tachycardia. The focal atrial tachycardia, it will have a deformed D-shaped P wave, but there will be the shape will remain the same with every complex. ठीक है? In multifocal, the P wave, the every time P wave is appearing with a different shape, different face. But in case of FAT, focal atrial tachycardia, every time P wave is appearing, although it is D-shaped, it's not a normal shape P wave, but the shape will be the same, whatsoever shape she adopts, the wife P wave adopts, but it will be the same. Remember, P wave is wife. Okay, now, and then we have already discussed the junctional tachycardia in detail. So that's it about the supraventricular tachycardias. Now about the ventricular problems. Premature ventricular complex. Now that was about the supraventricular. Now we will talk about a little about the ventricular arrhythmias and whatsoever. Now premature ventricular complexes, PVCs, the famous PVCs. Usually rhythm is regular, so they are not that harmful. Sometimes they're even benign in most of the cases. Rate usually normal, peer interval is normal. Unifocal PVCs means same shape, again same as that of the focal atrial tachycardia. So unifocal PVCs are same as focal atrial tachycardia, because in focal atrial tachycardia, PVC, although the P wave was distorted, but it will be same. So again, in case of unifocal PVC, it will be same in shape, but distorted. As the name indicates, multifocal means the PVCs are appearing every time with a different shape. So as you can see now, it has adopted this shape over here. And on this side, in the next few cycles, it will appear like this. So due to ventricles depolarizing prematurely in response to a signal within the ventricle, this is the pathophysiology. You want to remember it, memorize it. Otherwise, there's no need too much focus on the pathophysiology right now at this stage. You just have to identify what's going on. They differ in appearance. The curious complexes differ in appearance, so would be called multifocal PVCs. And this is bigeminy. Bigeminy means the PVC has started appearing alternating with normal curious complex. One will be normal curious complex, the other will be the abnormal. Then normal, then abnormal. When it started appearing like this, we call it bigeminy. This is different because over here it's appearing at different intervals and different timings, sometime upwards, sometime downwards, sometime in between. But bigeminy means that it is alternating with a normal curious complex. This is bigeminy. This is what? These are the triplet PVCs. Occurs in group of 3. So this is the ventricular tachycardia. Now it's in all the leads, it's everywhere. It's just coming one after the other, and there is no normal curious complex. The broad complex regular tachycardia is monomorphic. Now its name is broad complex regular monomorphic tachycardia. Although the name sounds very scary, but it's very self-explanatory name. If you just focus on the name, as you can see, broad complex, regular, all the R are coinciding, and monomorphic. Monomorphic means same shape. Sahi ho gaya? Rhythm is regular, rate is more than 180, 190, curious complex, duration prolonged, P wave, you cannot see it. Due to abnormal tissue in the ventricle generating a rapid and irregular heart rhythm, poor cardiac output, patient can go into cardiac arrest if not managed. Sometimes you have this, but patients are stable. That is known as stable VT, and you may have an unstable VT as well. That was my experience from the past. So patient is YT stable sometimes, and drugs. And if patient is YT stable, you can manage it with drugs and cardioversion. And if patient is in shock, patient is unstable, then you have to defib the patient. So it may appear like this, different shapes of ventricular tachycardia. This is a full 12-lead ECG of ventricular tachycardia. In different leads, it will appear differently. Now, ventricular fibrillation, that is known as the cardiac arrest as well. Disorganized electrical signals, rhythm irregular, rate more than 300, disorganized, unrecognized, curious complex, duration not recognizable, P wave hoti nahi hai, not seen. Also known as cardiac arrest, patient always in shock and unconscious and needs immediate defibrillation. This is asystole. Rhythm flat, कोई rhythm नहीं है, 0 beats, no QRS, no P wave, start CPR. Now this is a very important slide. I want all of you to take a screenshot and give me 1 minute. I have to receive a call. Now let's divide this in different parts. First of all, this one is over here, this part, and then this part. So this slide has 3 parts. First of all, when you look at the ECG, you have to look for the P wave. After all the things like rate, rhythm, you have to look for the P wave. Is P wave there? Yes. No. Yes, but P wave is abnormal. Good. Now, coming here. Yes, P wave is there. If P wave is coming and it's always related to the QRS complex, yes or no? Yes, it is related to QRS complex. Means it's coming just at a regular interval, just before the QRS complex. It means that. So, yes, it is related to QRS complex, yes or no? Yes, it is coming with the or related to the QRS complex. Now look at the PR interval. Is PR interval normal? It's sinus rhythm. No worries. If PR interval is long, it is first degree AV block. Theek? Good? Easy? Now, again, P wave is there. It is related with the QRS complex. No, it's not related. It's not related. It's coming on its own and QRS complex is coming on its own. So sometimes it's related and sometimes no, and sometimes balki never. It's not related to. Sometimes and sometimes not. So if it is not related to QRS complex, sometimes it's second degree AV block. But it is totally not related to QRS complex. As you know, as the third degree AV block, wife is coming on its time, husband is coming on its time. Yeah, the story, remember that story? So it will be third degree AV block. Okay? Now, just forget this part right now. Just for now, just forget this. So this is the first degree, second degree, third degree AV block. ठीक हो गया? P wave is there. It means atrial activity is going on. And P wave is present. Yes. It is related to QRS complex. Yes. So look at the PR interval. It's normal. Yes. It is sinus rhythm. PR interval is long. It is first degree AV block. Now P wave is related to QRS complex. Sometimes no. And other time totally no. So sometimes when it's not related to QRS complex, it's second degree AV block. But when it's always not related to QRS complex, it will be third degree AV block. Both are coming independently. P wave is totally coming irrelevantly to the QRS complex. Now coming here, is there P wave? There is no P wave. It means there is no atrial activity. So what's left? QRS complex. Now you have to comment on QRS complex. Now look at the QRS complex. First of all, QRS complex is narrow, QRS complex is wide, or there is no QRS complex. If there is no QRS complex and there is no P wave, it's either VFib or it's asystole. You have to do CPR or DFib. Now, if QRS complex is narrow, remember the narrow complex tachycardias? Remember? So now, if it is QRS complex is narrow, you have to look it is regular or it is irregular. If it is regular, it may be atrial junctional rhythm. Yeah, SVT, yes, or it may be SVTs. Or if it is irregular, narrow but irregular, it is atrial fibrillation, flutter, all those. ठीक है, वो जो हमने एक और से पहले chart किया. Now coming to the QRS complex, if it is wide, it's regular, it's ventricular regular, monomorphic, regular, VT, stable VT. And when it is irregular, it's it may be ventricular tachycardia or sometimes SVT with aberrancy, वो भी हो सकता है. So that's all about it. No, अभी कुछ रहता है. Okay, and let's say if there is P wave, but it's there, but it's abnormal, D-shaped, inverted, whatsoever. Now, if it is inverted, pre, post, or mix in the QRS complex, it's maybe junctional tachycardia. Yaad hai? Remember? And some, or it may be a flutter. Flutter में abnormal saw shape P waves होती है ना, fluttering P waves. So it may be a atrial flutter. So that's it. Okay, now these are different ECGs, ECG rhythms I have for you all, and everyone have to comment. And online audience, my online students can comment in the box. First degree, first degree, first degree, first degree. Okay. Peer interval is prolonged, but peer interval is fixed. दोबारा देखें. तो दिस इज फर्स्ट डिग्री. इसका बताएं. इसमें आप हार्ट रेट जरूर देखें, बिकॉज दिस वन इज टेकन फ्रॉम अ रियल पेशेंट. दिस इज नॉट अ जनरेटेड वन, दिस इज फ्रॉम द रियल. जी, my online audience, I really need your feedback so that I would know that you have learned something from today's session or not. So what is this one? जी, रमीशा क्या है ये बताएं. अच्छा, तलहा कह रहा है थर्ड डिग्री. और कौन कह रहा है थर्ड डिग्री? डॉक्टर हुमैरा, दिस इज नॉट सेकेंड डिग्री. प्लीज लुक अगेन. Look at the P wave. Look at the QRS complex. There's dissociation between the P wave and Q wave. There's a dissociation between P wave and Q wave. And that means the peer interval is not regular. First of all, the peer interval is not regular. P wave is coming out on its own anywhere between, and you can see now it's appearing here, it's appearing here, it's appearing here, just near to that, after that, before that. QRS complex is coming on its own. These are the QRS complexes, Dr. Humaira. These are the QRS complexes, as you can see, where my cursor was there. So this is the third degree AV block. Total dissociation between the two. First of all, the dissociation between P and Q, QRS complex, and secondly, peer interval is not fixed. अच्छा, ये चला नहीं. I think ये hang हो गया है. अच्छा, anyways, I'm sorry this is not working, but at least you can see this, its shape, and you can comment. It is monomorphic VT. Yes, very good. This is monomorphic VT. I don't know ये चला क्यों नहीं यार. दिल टूट गया मेरा. Okay, so this is VF. Yes, Ahmed, you're right. This is VF. हाँ जी बच्चों, आप लोग VF confirm सारों का एक का इस पे. Okay, this one. ये चल गया, शुक्र है. Now this one. Okay, SVT वाले. SVT. Solomon, Ahmed, right. SVT, Amna, SVT, Jennifer, SVT. Okay, good. Yes, Saima, SVT, very good. चलें जी, आगे चलें. Now this one. जी, online audience. This is a broad complex tachycardia. So it is most probably it's VT, or it may be another thing, aberrancy with SVT. It can be aberrancy with SVT, but usually we take it as VT. Yes, Ahmed, you're right. Exactly. Now, what is this? G, online audience, what is this? G, this is TDP. Rabia, what is TDP? What is TDP? I'm sorry. Also, tortoise deepen. Okay. That is abbreviation of that. All right. I'm totally old school and I don't know the abbreviation about it. Yeah. I just got it. Thank you. Yes, Saima, this is SVT, or it may be junctional rhythm. Yes. It's not atrial fibrillation because the rhythm is regular. You can see the RR interval is totally normal. ठीक हो गया. All right, चलो next पे चलें. ये भी अभी चलेगी, I hope so. Yes, a very dim one, but can you comment on this one? Yes, Amna, this is SVT, or you can say it's a junctional rhythm, maybe junctional rhythm. वो यहाँ आके थोड़ा ठीक हो गया था ना, और इतनी ही है, छोटी सी थी. This is SVT. चले मैं आपकी मुश्किल हल कर देती हूँ. Okay, next. ये क्या है? ये बताएं. Can you look at the waves? Look at the shape of the waves. This is Ahmed, this is not SVT, this is not third degree. Look at the waves. There are a lot of waves in between. 4 in 1, 3 in 1. Yaad aaya kuch? Can you recall? Look at the waves. Actually, this video is stretched to fit in the screen. So that's why the waves are stretched. Basically, these are a lot of yes, this is atrial flutter. Good. Now everyone is getting it. Yes, this is atrial flutter with occasional atrial extra beats. The AHA guidelines. This is not from me. This is from the AHA. I have just summarized the whole management plan of the arrhythmias. Now, look on this side of the slide. Let's say there is a bradycardia. If it is stable, you have to observe the patient. If bradycardia and patient is unstable, these are the ACLS guidelines. These are not from me, right? The AHA ACLS guidelines. You can give atropine 6 times in 0.5 milligram, 6 times. If not working, you can go for transcutaneous pacing, and if it is not working, you can go for transvenous pacing. And you can also take the expert opinion, that is referred the patient to cardiologist. But let's say being anesthetist, you are working in OT, at least you can do up till here. And meanwhile, call the cardiologist. Now, if there is tachycardia, it is stable or it is unstable. Unstable, tachy mein you can cardiovert. Even SVT is unstable, AFib is unstable, VT unstable, you can cardiovert. Unstable means patient either is dizzy, patient is developing hypotension or losing conscious, conscious, so you can cardiovert the patient. If patient is stable, look for its narrow complex tachycardia or its wide complex tachycardia. In any kind of narrow complex tachycardia, you can start with the vagal maneuver. You can go for adenosine. 6, 12, 12 means 6 milligram, 12 milligram, 12 milligram. Milligrams mein hota hai na? And if it's not working or it has transiently worked, temporarily worked, then switch to antiarrhythmic infusions. And in case of wide complex tachyarrhythmias, stable tachyarrhythmias, you can directly go to antiarrhythmics. Usme adenosine nahi dete. Do not give adenosine. So about adenosine, I thought it's my responsibility as I have mentioned it. So I should also mention when to give it, when not to give it. In stable, regular tachycardia, narrow complex tachycardia, you can give it safely. And in monomorphic, wide complex, stable VT, you can also give it. With a single shot, there will be that will not be harmful for the patient because you have to give it some time to differentiate between VT and SVT with aberrancies. Cardiologists should do that. If you're not sure, don't give adenosine. Now, when strictly not to give, irregular tachycardias. Irregular tachy कौन से? AFib, flutter, fibrillation, ज़्यादातर वो थे. Multifocal, MAT, polymorphic wide complex, don't give it. In heart transplant patient, don't give it. So that's all. Take care of you all. Thank you so much for joining me. We also had foreigners today. If they have no reservations, can I know that from which countries you were here and you have joined us? I cannot even pronounce some of the names. There was Barsha, there was Fatma, there was Solomon, and so many others. So can you tell me from which countries you were here? If there is no, if you don't have any reservations about it. Yeah, okay, Pakistan. Sawat. SVT Sawat. Okay, Farida was from Uganda. Okay. Okay, so you are from Uganda. Okay. Link was shared in WhatsApp group. USA. Okay, Barsha. Barsha is from USA. Right. So it was nice having you all from different cities and different countries. So that was a really nice session with you all. And I really appreciate that you actively participated and showed really a great enthusiasm joining me at the 8 o'clock in the morning in the foggy mornings there. So that was really good to have you all. Thank you so much. With that, I will take leave now and have a good day.